Let's talk about something that often starts with an incredibly common feeling: back pain. But what if that nagging pain is actually a signal for a condition so rare and so high stakes, it's like a medical mystery? Today, we're diving into the journey of a thoracic disc herniation, a true surgeon's dilemma. So, just how rare are we talking? Well, think about this number. Thoracic disc herniation, or TDH, can affect as few as one person in a million. Right away, you know this is not your typical slipped disc. This is a whole different beast. So what is it exactly? Well, a TDH happens when one of those cushioning discs in the middle of your spine, that thoracic region, starts to bulge out. But the real kicker here is the location. It's happening in a part of the spine where there is very, very little room to spare, which means it can put direct and really dangerous pressure on the spinal cord itself. And that brings us to the patient's journey. It almost always kicks off with a symptom we've all probably felt at some point. But in this case, it's a sign of something way more complex and way more risky. You heard that right. A whopping 92% of the time, the first alarm bell is just pain in the middle of the back. You can see how easy that would be to dismiss, right? But it's actually the very first clue in what becomes an incredibly challenging diagnostic puzzle. So, what makes this specific area such a danger zone? Well, a few big things. First, the spinal canal itself is just naturally narrow there. It's a tight corridor, so any bulge is an immediate problem. Most of these herniations happen right at the T11, T12 level, which is a high stress spot where the rigid rib cage meets the more flexible lower back. And this is absolutely crucial. The blood supply to the spinal cord in this area is super fragile. It has these vulnerable watershed zones that, if they get compressed, can essentially be choked off, and that can lead to catastrophic damage. With the stakes this high, you can imagine that diagnosing the problem with absolute certainty is everything. So let's look at how doctors actually get a clear picture of what's happening inside. A standard x-ray just isn't going to cut it here. To really get a handle on the danger, clinicians have to see the soft tissues, the disc, the nerves, and the spinal cord itself. And this is where advanced imaging becomes the real hero of the story. And here it is. This is the aha moment. That image on the left, the sagittal view, shows the disc material pushing out where it shouldn't be, but it's the image on the right, that top-down axial view, that's the real showstopper. You can literally see the herniated disc squashing the spinal cord. This is the picture that changes everything for the patient and for the entire surgical team.
But it's not just one scan and you're done. It's really a multi-tool approach. The MRI, as we saw, shows the herniation and if there's any swelling in the spinal cord. Then, the CT scan is vital because it tells them if the disc is soft or if it's hardened up like bone. And that detail completely changes the game plan for surgery. Finally, an angiography can map out a critical artery to make sure surgeons know exactly where it is so they don't damage it during the operation.
So, once the problem is fully mapped out, the surgical team arrives at a major crossroads. See, there's no single best way to do this surgery. The path they choose depends completely on the unique details of that specific herniation. Now, surgery isn't always the first move. For just back pain, they'll try conservative treatments first. But when those don't work, or if a patient's neurological symptoms are getting worse, or if there's been a severe injury, surgery becomes the only real option left on the table. And this is where that surgeon's dilemma really comes into focus. There are three main ways to get to the problem. The posterolateral approach, from the back and side, is good for softer discs, but the view isn't great. The lateral approach, from the side, gives a better view but means going through a lot of muscle. And then there's the anterior approach, going in from the front, right through the chest. It gives the best access for those hard calcified discs, but it comes with a much higher risk of lung complications. It's just a profound balancing act of access versus risk. So no matter which path they choose, the procedure is absolutely filled with risk. The whole goal is to relieve pressure on the spinal cord, but the surgery itself can open the door to a whole new set of dangers. And I mean, just look at these numbers. They're pretty sobering. The rate of complications linked to these surgeries can start at 12% and go all the way up to a jaw-dropping 48% in some studies. This is not a routine operation, not by any stretch of the imagination. The major risks really fall into three main buckets. First, as we mentioned, are the lung complications, especially with those anterior approaches. Even scarier is the risk of neurological deterioration. If you disrupt the cord's delicate blood supply, you could cause permanent weakness or even paralysis. And finally, there are dural breaches. basically tears in the protective sleeve around the spinal cord, which can cause these painful leaks of spinal fluid. Okay, this quote from the source material just blows my mind. It really shows you the kind of split-second, high-stakes decisions being made in the OR. To stop from tearing that super delicate lining while removing a disc that's basically turned to rock, a surgeon might choose to intentionally leave a tiny piece of it behind. It's an unbelievable, calculated trade-off to prevent a much, much worse problem. And if a tear does happen, the response has to be incredibly meticulous. It's like a 4-step emergency protocol. It starts with immediate stitches, which are then reinforced with the patient's own tissue. After surgery, they might use a drain to lower the fluid pressure. But even after all that, if a persistent leak forms, there's a 50-50 chance they'll need another surgery to fix it. So, after this intense journey through diagnosis and a super high-risk surgery, what does the future actually hold for treating this incredibly challenging condition? Let's just boil it all down to the core problem, right? The entire goal is to free the spinal cord from that pressure, but the very act of doing it puts the cord at enormous risk. It is the ultimate surgical tightrope walk. And this brings us to the final and maybe most important question. In a surgery where a single millimeter can be the difference between a great outcome and a catastrophe, how can we possibly improve the odds? And the answer really lies in technology. The path forward is through tools like intraoperative navigation. Think of it like a GPS for the spine. It gives surgeons a real-time 3D map while they're operating. These are the kinds of systems that promise to bring a new level of precision to an incredibly delicate surgery, and hopefully finally tip the balance in this critical surgical dilemma.